As the coronavirus pandemic took the world by storm, for the first time, many people in developed countries understood what it is like to lack access to essential medicine they need to survive. For people in poor countries, lack of access to medicines has always been a problem. This podcast explores the access to medicine issue and how we can promote global health more broadly. Famous scientist Marie Curie once said, "Talking is the best medicine." In this podcast, we will heed the advice of Curie and discuss how we can ethically and effectively tackle the health challenges currently affecting our world. Throughout this series, we will break down and explore fascinating new research being conducted by leading researchers and activists in the diverse field of public health who've dedicated their lives to understanding the problems and identifying the solutions to health crises that impact millions of people around the world. So sit back and enjoy this episode of Talk is the Best Medicine, brought to you by Global Health Impact Project in partnership with PlankSip.
This episode is a bit different for us, as we have focused mostly on access to medicines for people who want them, but sometimes people don't want to take vaccines and other medicines when they have access to them. When, if ever, is it acceptable to mandate vaccines or even to make them a benefit, like to international travelers, available to only those who are vaccinated? In this and the next episode, we consider the debate over vaccine passports. Today, we'll hear from Dr. Govind Persad. Dr. Persad, welcome to the show. Good day.
Hi, good.
So I'd like to start off by having you tell us a little bit more about yourself and how you got into public health policy.
Sure. So my name is Govind Persad. I'm an assistant professor at the University of Denver's Sturm College of Law, where I teach health law and bioethics. And I'm also a Greenwall Foundation Faculty Scholar in Bioethics, which is a grant to conduct bioethics research. I have a Ph.D. in philosophy and a law degree from Stanford. The way I got interested in public health ethics and policy generally was between undergrad and going to graduate school. I did a 2-year pre-doctoral fellowship in bioethics at the National Institutes of Health, where I researched some issues on the allocation of scarce resources. And then also, this is actually in the National Institutes of Health Clinical Centers hospital. So we all the fellows served as ethics assistants on the ethics consult service and helped to participate in organizing the ethics consults as fellows for researchers at the NIH who had ethical questions. And then before actually I started at my current university, I was for a couple of years a assistant professor at Johns Hopkins in their School of Public Health, which obviously was a place where public health policy was discussed quite a bit. So in terms of public health policy, I've worked on a variety of issues, including both ethical issues connected to sort of traditional public health restrictions, like travel restrictions, and then also on fair distribution of scarce medical resources like vaccines or antivirals or other scarce interventions.
Well, that's very interesting, and thank you for sharing that about your experience. So let's get into it. How ethical are immunity passports, and are they discriminatory?
Sure. So let me say a little bit about, so people use this term immunity passports in a way that it's often not clear what exactly it means. When I originally wrote about this back in 2020, this debate was going on before the advent of a vaccine. And so the question was about whether prior infection with COVID-19 might support a basis for regarding some people as immune as opposed to others. And I think, as I talk about in the article, one challenge for that type of immunity passports, or that type of, we prefer to use the term in the article sort of immunity licenses or immunity verification. And one reason why is that immunity, using the term passport suggests that any place you consider immunity would be about sort of an all or nothing permission in terms of access. In contrast, licenses or certification might be where immunity is relevant for specific activities. So think about, we talk in the paper, driving. It's not that you need a driver's license to do anything. You do need one to do a lot of things that require driving. So in order to drive a car, you need a driver's license, but not in order to do something that doesn't pose the same kinds of dangers if you do it without a driver's license, something that's not driving. Similarly, there might be some activities where immunity is very important. For instance, visiting somebody in an assisted living facility, and others like going for a walk outside, where immunity to COVID-19 is not very important. So that's one theme that we talk about in that early paper. The other is that, which I think is a difference, is that with the older proposals to grant licenses based on prior infection, a concern is that that may create an incentive to seek out infection in order to become licensed, and that might create unnecessary risk or pressure on health systems. Now that we have vaccines, the activity that's being incentivized wouldn't be becoming infected, which is poses this high risk to health systems, but becoming vaccinated, which actually provides a benefit to health systems by reducing your risk of ever becoming seriously ill. So I think that's one way in which the debate has changed. And I personally thought that the strongest argument against the use of immunity licensing prior to vaccination was this concern about incentives. Now that vaccination is available, I think the case for it being ethical to treat people who are vaccinated differently from those who are not, in most settings, is pretty strong. We can talk about specific examples, but in terms of being discriminatory, I think we see for other vaccinations, a variety of contexts where they are required for certain activities. So required to attend school, which is a matter of very fundamental interest, yet appropriate to condition on something like a measles vaccine. You see it for certain vaccines needed for certain types of international travel in settings where there's a high risk of exposure to certain diseases. So with respect to immunity from vaccination, I don't think it is at least obviously discriminatory because it's differentiating people based on a factor that is relevant to their health risks, as opposed to something like, say, their religion that's not obviously relevant to any sort of health risk they might pose or face.
Yeah, I thought the paper was well argued, and thank you for clarifying the terms of immunity licenses. There's a nuance that I'd like to focus on here. When it instead of licenses versus passport, but have you considered the word immunity and replacing it with something like resistance? If you know where we're going with this particular one, vaccines are not 100% effective, and the scientific community has been frustrated by vaccinated individuals treating vaccines as a magic shield and stop protecting themselves, if that makes sense.
Sure. Yeah. I mean, I think it's a good point in that I think we often do use the term immunity for vaccines, and I think it'd be more accurate to think of it, as you say, as increased protection, reduction in risk, as opposed to absolute prevention. There's no medical intervention, including vaccination, that's going to be 100% effective against an outcome. You can always have situations where a given outcome occurs. And one of the differences with the COVID-19 vaccinations is that typically when people get vaccinated, they're not being vaccinated in a setting where there's a sort of rampant outbreak going on. So the vaccines that were used to things like measles or polio, I normally am not being exposed to measles in my daily life because vaccination rates are so high and the level of spread is so low. in contrast, even a highly effective vaccine, even if you had a 99 as opposed to sort of 90-ish% effective COVID-19 vaccine, effective against infection or against um, uh, hospitalization, say, if you have such high rates of exposure, you're right that you're not going to get a vaccine that is 100% protective. So you could say um, resistance or protection. Clearly, particularly with respect to severe outcomes, the vaccines are highly protective, but in a setting of such substantial exposure, there's still going to be some people, despite being vaccinated, who do become infected. People have made the analogy to a soccer goalie that even if you have a very, very good goalie as opposed to no goalie, if you have, thousands of shots on goal every day, some are going to get through. And so I think uh, at the same time, you said something about people being frustrated about people treating vaccination as a magic shield. Certainly, I don't think it should be treated as a magic shield, but I do think it can be sensible for people who are vaccinated to make different choices and to impose different public health restrictions on them compared to people who are not vaccinated or otherwise protected. So we could talk a little bit more about that. I don't think you should treat it as a magic shield, but I do think that there are real differences between being vaccinated and not vaccinated, which is part of why we would want more people to be vaccinated.
Yeah. Okay. Okay. All right. That sounds good. You mentioned the concern of stigma that people lacking immunity licenses might face in society. What we see that today with vaccinated people often looking down upon those that are not vaccinated, and whether it's looking down or there's a discriminatory sort of assumption there. My concern is not with people who choose not to be vaccinated, but with those who cannot be vaccinated. Will we avoid specifics on which groups should or should not be vaccinated, since decisions can depend on the type of treatment one is receiving to know if they're at risk for adverse reaction? People should always, yeah. So what would you say about that?
So yeah, I mean, in terms of the contraindications to vaccination, for the COVID-19 vaccines that are available here, at least, I think the set of conditions that are contraindications are pretty minimal. The sort of typical analysis is that you would need to be allergic to the ingredients in both of the available vaccine types, which I believe is a fairly small subset of people. What I thought you were going to ask about in the context of international travel is a slightly different question, which was about. What I would say is that in the setting of the US, um, there are very few people who strictly can't be vaccinated no matter what. There are some people who have continued to face access barriers to being vaccinated, although that's progressively decreased over time as you see universal availability and then continued efforts at outreach and so on. And then you also, beyond people who have access barriers, you have people who choose not to be vaccinated for various reasons. And we could talk more about those reasons, but those are all reasons that have to do with choice as opposed to not being able to access. I thought that you might ask about, or a slightly different question, which is what about people coming from countries or who are in countries where there is not the same degree of vaccine access as there is here? How to think about that? And I do think that presents
Well,
different.
let's get into that just in a minute. And I really hate to interrupt, but there was one really excellent example where an individual has CLL cancer, which is associated with weakening immune system, and they can be safely vaccinated, but there's only a 39.5% chance that they'll respond to vaccine, with several cases not developing antibodies at all. What should the immunity license protocol be for those individuals who attempt to be vaccinated but cannot for antibodies? And then, of course, I want to get into the conversation about low vaccinated countries. So,
The
yeah.
CLS case, I think, is a really interesting and useful example to think more about. And in a way, sort of explains both part of why we might want a system of recognizing that some people are at different risk from others, and then thinking about which activities you'd want to condition on being at lower risk. So it's sort of analogous to driver's licenses. So there are some people that, because of their medical condition, it's not going to be safe for them to drive. Not because, this is not an issue of not being interested in driving, but not being safe even if they wanted to. And you could think of CLL as being analogous for immunity to some extent, that here it's not that it wouldn't be safe for them to be vaccinated, but the vaccination won't be protective as extensively against bad health outcomes. It would be sort of analogous to somebody who might have a medical condition where they have frequent seizures, where even if they train to be the best theoretically at driving in the world, it might still not be safe for them to drive because this condition could unpredictably expose them and others to risk while driving. So for the CLL patient, I think the question is going to be, what ways of recognizing the fact that they are different in terms of their protection would be appropriate? And I think that's going to depend on what the benefits and risks to them and to others are of their participating in any given setting. I think, in some ways it's going to be very similar to the analysis of any other medical condition that might create a need for a reasonable medical accommodation. And so in employment, for instance, there's I'm trying to remember the name of the case, a very famous 9-0 Supreme Court case that says that if an employee would be at high medical risk of being injured by some activities that they participate in as part of their employment, it can be okay to exclude them from employment or from that aspect of employment, even if the risk they face isn't anything that they chose. So the idea is that if you've, because of a medical condition, are at high risk, that risk can justify not having you participate in certain employment activities. And that would be applicable for the person with CLL as well. At the same time, there might be both societal reasons and legal obligations on the business to ensure that a person with CLL who, say, might be at high risk in a job that includes high COVID-19 exposure is reasonably accommodated in other ways. So if the business has positions that are remote, that can feasibly do the same job. So maybe, it would be hard to have somebody who is a remote checkout cashier, but it might be more practical at a larger business like, say, Amazon, to have the person work in a remote setting rather than in a warehouse. Similarly, at a social level, somebody with CLL, you might make accommodations where, similarly for people with other immunodeficiency before COVID, you might have other programs that try to assist them in being able to safely obtain various kinds of goods or services. I don't know if that's helpful in sort of thinking about this example.
Yeah. Okay, so in the paper, this perspective was written last summer, and since then things have worked out in. I'm just curious if you're familiar with an example like Africa, where the low vaccination rates are in a range of 3 to 5%, and how that.
Yeah, I mean, in Africa, I always hate to talk about Africa as a monolith because the countries are quite different. I think you certainly see some countries that I think have had very, very low rates, and some of them for a variety of reasons, some due to supply, some due to other logistical challenges. So South Sudan, say, has had very low rates. You see other countries, I think Botswana is an example, that have had higher vaccination rates than other neighboring countries. And I think they're, particularly if they had supply, might be able to vaccinate even more people. So I think certainly on a sort of regional basis, vaccination rates have been lower there. I think the story about why differs quite a bit from country to country.
Okay, perfect. Yeah, so now you discuss forgery of vaccination licenses, and how it would be fairly easy to prevent this by issuing cards similar to, and you've used the analogy of driver's licenses, so that really helps. How do you envision, these licenses being dispersed? And could you talk a little bit about the aspect of forgery as they pop up in everything from NFL athletics to other potential instances?
Yeah, I mean, it's interesting because despite the technological sophistication in the US, the vaccination verification is much less robust than the verification for something like being a licensed driver, or, I'm not a pilot, but I would imagine that pilots' licenses might have similar sort of greater degrees of um, verification and follow up. I think, perhaps in part for political reasons, there's been a resistance, a reluctance to. There's one question about, when you want, for what you want to require proof, but it seems like if you think that there are any where you'd want to require proof, it would be nice to have a way of proving uh, vaccination that is more difficult to forge and also sort of easier for somebody to, there's a day where I just misplaced my vaccination card. I had to go hunt around the house for it. If you had, and it's not immediately clear to people sometimes how you can get one reissued. So I guess what I would say is that I do think it's an issue. I don't think that it's really a special issue because it arises for every type of licensing or verification documents. So for driver's licenses, for passports, for other sorts, student IDs, any type of proof of identity or status has these challenges. There are technical experts, not me, who have worked on ways of addressing some of the challenges when they design, even credit cards would be another example, right, where you want to have. And I think almost all of us carry one of these forms, whether it's a driver's license or some type of credit card, debit card, ATM card, student ID. The fact that there's not something like even the sort of debit card degree of sophistication for vaccination, I think, is interesting, and I think does make the problem more challenging as it is right now. But it doesn't seem like one that is fundamentally insurmountable. In terms of developing country settings, one interesting thing that you see in a lot of developing countries is you actually see the more widespread use of mobile phones for some applications than you see here. So for money transfers, for instance, it's sometimes even more widespread than the use of something like Venmo or other transfer apps here. But again, I think this is in some ways more of a question really for technical experts in implementation. I don't think, unless somebody thought that, there was something unethical fundamentally about driver's licenses, that the question of forgery is kind of a fundamental ethical objection as opposed to an important but surmountable practical issue.
I would imagine that there's only a small percentage of the population that would go to the extent of trying to forge. But I mean, hey, that's completely an assumption. I know that there would be quite an effort to do that and maintain that. I don't know if that is incentive adverse in just the effort to
I mean, you
actually
see that for
produce them.
passports, for driver's licenses as well, I think. Again, I'd be able to sort of look at empirically to see how prevalent is that actually, and are there approaches that reduce it at sort of reasonable cost in terms of. The flip side is obviously if you have more steps to prevent forgery, you don't want to have that lead to the cost or burden becoming very much higher to be able to obtain verification. I think that's just a very classic trade-off in the design of any of these systems of verification.
Yeah, the next question actually has to do with an FDA approved antibody test. And this would be for the instances where COVID-19 is, as you know, the infection after the virus, whether you've received the vaccine or not, is, I think, pretty similar. So what the idea is that if there was an FDA approved antibody test that people could qualify for in an immunity license, would you think that this would be too expensive of a program to implement?
I mean, my concern in some ways is less about expense, because expense addressed if you wanted to just subsidize access, for instance. I think the challenge that continues to be the case for antibody tests, and for this question of what exactly prior infection gets you in terms of long-term immunity, still remains uncertain in the way that we talked about back in 2020. So I still don't think that we have. Basically, what I would say is that in some ways, now that we have vaccines, the issue of looking at past infection is largely less urgent, because it's much easier to verify that in general with vaccination, you have protection. I think one thing that would benefit from more scientific research, and your CLL example is a nice one, is to understand what people call the immune correlates of protection. So other than seeing if somebody gets COVID-19 when they've been exposed, and that can be very difficult to know, how else can we tell that someone is protected? And I think that we still don't have as full an understanding as we might like of what exactly the immune correlates of protection, especially against severe disease, are. Because you see, again, this would really be a great question for a scientific expert. You see some drop off in circulating antibodies, as you would expect, along a period of time after vaccination, and probably a period of time as well after prior infection for some people. But there are other parts of immune response that may still be able to kick in and deal with an infection before it becomes severe. So immunologists talk about what's called a T cell response. And I think we still, and if you're just doing antibody tests, that may not accurately track what there are also different types of antibodies, neutralizing versus other antibodies. And so I think
Right.
that's an area where I think really I would want to sort of ask scientific experts about what tests look like they're the most predictive. And I actually don't think, in terms of, basically, we know that if you've been vaccinated, your protection is dramatically increased. But in terms of then looking afterward to see, say that you don't know whether somebody was vaccinated or not, and you're just trying to figure out by looking at them, looking at other metrics, whether they're protected, we still don't understand the correlates, I think, as well as we might like to. And I think that's a good area for continued research that could be valuable in situations like, kids who aren't eligible, or your CLL patient who may not know how protected she is. Those correlates could help tell us more about when somebody gets to be protected.
So, with the idea of freedom of choice in the country, and people that are very vocal on freedom of choice, whether to vaccinate or not to vaccinate, do you think we should still use incentives, or should we start phasing in some sort of a compliance violation, dare I say punishment, but this type of thing?
Sure. So this might, I think, question takes us somewhat afield, I think, from the paper, but I'm happy to talk a little bit about it. So I think the question with respect to, say, people, now it sounds like we're talking about people who choose not to be vaccinated despite having access, so not your CLL patient, for instance. And in this sort of situation, I think this is something Holly Lynch at Penn and I have written about. This is really a question about when it's appropriate to ask people to bear certain consequences of their choice. So if a consequence of choosing not to be vaccinated is that you're at different risk from someone who is vaccinated, then I think it can be appropriate for public policy to respond to people who are at different levels of risk in different ways. And so one way of thinking about it is that, if everybody had been vaccinated, was not possible. But imagine that at the start of the COVID-19 pandemic, everybody had had the degree of protection that people who are vaccinated have now, or at least the population level of protection had been at the level that the population would have now if there were a high level of vaccination. Under that circumstance, it, I think, wouldn't have been viewed as appropriate under principles of public health ethics to impose the sorts of, say, business closures or social distancing restrictions or some of the other travel limitations across borders that were often justifiable in light of the fact that people were entirely unprotected. So now, sort of fast forwarding to today, I think the question is going to be, when some people have reached a level of much greater protection than others, um, is it appropriate to still subject them all to the same policies? And I think there's a good basis for saying, that doesn't make sense when the some people are still facing the very serious health risk and maybe also presenting a health risk to others. And for other folks, that's much more sort of limited or attenuated. So I think the idea is that you still have sort of freedom of choice to maintain the risk level that you had in 2020. But typically, I don't see people who are unvaccinated saying, continue to impose all those restrictions just on me. Typically, what people are asking for is to remain unvaccinated but be exempted from those restrictions. And I think that's a little bit harder to see why that would obviously be the case, at least in settings where there continues to be sort of medical pressure on hospitals and other facilities.
Right. Okay. So how do you feel about President Biden's vaccine mandates for companies with over 100 employees in the name of worker safety?
Yeah, so I think it makes a lot of sense to, one way of thinking about it is that if you have settings like in-person work where there's a risk of spread between people, it makes sense to require measures in that setting to reduce spread. And one way of thinking about the recent OSHA rule, which I actually was writing about this yesterday, a court enjoined the rule, but I think the reasoning of the court was really not convincing. And enjoined meaning the rule couldn't go into effect. And one of the things that is interesting about the OSHA rule is that it's actually not even a vaccine requirement. What it is a rule that either you have to be tested once a week, or if you want to be exempted from that, you have to be vaccinated. And that's only, again, if you are working at a covered employer, that you have to do either. So in some ways, the question is really about whether there should be allowed to be a vaccine exemption from a testing requirement, and then about whether it's appropriate to impose a testing requirement on people working in person. And I guess I tend to think that, setting aside this question of a direct vaccine mandate, it's not very obvious why there would be a reason to think that a testing requirement is an unacceptable restriction on freedom. And then um, exempting vaccinated people from the testing mandate seems to just be an appropriate way of recognizing the differential level of risk that people may face or may pose. So I think a lot of universities, for instance, may test people that are not vaccinated more often than those that are. And I think, again, the sort of testing frequency just ends up being something that reflects different risks. So, yeah, especially in I would say, especially in the form that the OSHA rule took, where it's a vaccine exception from a testing requirement. I think the arguments against it don't seem, you know, particularly ethically clear to me. If people don't want to be vaccinated, then they'll just be tested once a week. So.
Yeah, I really have to congratulate you on a side note, because the fact that that you're involved in law means that in your academic field, it's obvious that you're looking to the field, but it must be exciting that you're contributing to the shaping or monitoring of some some laws, whether there's Supreme Court judgments. I think
Oh, I
that's
certainly
got to be
don't know
exciting.
that I've been influential in any way that's contributed to the development of any Supreme Court judgments. It is nice to be able to, with legal training, be able to understand the really interesting things about the opinion that was temporarily blocking the OSHA requirement that workers be tested with a vaccine exemption. Is that there was a lot of what seemed like normative reasoning, ethical reasoning in the opinion that just seemed quite unconvincing. So for instance, the opinion insisted that being unvaccinated is, quote, non-economic inactivity. But of course, what the rule regulates is not being unvaccinated. You can be unvaccinated and hang out outdoors on a mountaintop by yourself as much as you want. The rule regulates working in person while unvaccinated and not regularly tested. And so you see just some, I think, misunderstandings of ethical reasoning in that judicial opinion, in the way that sometimes you see maybe misunderstandings of law in philosophical work. And so I think it is nice to have the background in two fields, the same way as I'm sure somebody who had a background in immunology as well as philosophy would be able to speak more informedly about some of the questions about correlates of protection that I can.
Right. Okay. Thank you for that clarification. Now we're going to skip over a couple questions because the clock is ticking. So I want to say some worry about inequitable effects of immunity certificates globally, and very few people in poor countries can access vaccines. If they're used for international travel, will people in poor countries who cannot afford to travel just have to wait? And what's the fairness approach on that as you see it?
Yeah, so something that I was on a panel on this with some folks from a variety of different countries, South Africa and some other places. What I would say is a couple things. One is that I don't think, again, compared to the driver's license analogy, basically, I think there are issues of fairness that are important to address by doing things like increasing access to vaccines globally, including for people who want to travel across borders. But I don't think the sort of inequity of requiring vaccinations is something particularly special against the sort of general background of the cost and other burdens associated with traveling internationally. So if I say I want to come to the US from South Sudan, I already have to be able to afford a plane ticket. I have to be able to afford accommodation in the US. I have to be able to obtain a visa for transiting the international border, which may actually be the most challenging thing. That can both cost money and require me to make sort of various forms of proof of, not that I won't overstay my visa, that I won't present any other sort of threat when I'm in the US. These are actually sort of far more challenging to overcome in many countries than it would be in some countries to be vaccinated. So at least as challenging or sometimes more challenging. And so, and at the same time, I think we don't think that the fact, and even if we think that some of those rules are inequitable or sort of compound inequities because, say, poor people in South Sudan are going to have a harder time getting a US visa, we don't think that that's a good reason if, say, there is somebody in the middle class in South Sudan who's able to afford the money to get a ticket and a visa. If she wants to, visit her daughter in the US who's having a baby or something like that, we don't think that the fact that the poor person in South Sudan isn't able to benefit from travel is a reason to kind of level down and say that nobody can travel. So I tend to think of a vaccine requirement for travel as being sort of a piece with other restrictions and preferable to a policy of kind of leveling down to create a hard border closure where saying, no, but the practice with COVID-19 up till we had vaccination for many countries, Australia is kind of a prime example, is to say nobody, no way, no how can come in. And I think with respect to that, actually permitting some access for vaccinating people is an improvement. And I think that just wanting to maintain absolute closures by not allowing vaccine-based differentiation would be a kind of leveling down that doesn't seem obviously justifiable. At the same time, I think it would be good to try to expand vaccine access. So one thing I floated in that talk that I think would be interesting to explore is in the US, when you fly, there's a security fee that you pay for airport security. It's attached to your ticket. And you could imagine a system where as part of international travel, there was a very small fee probably attached to tickets that was used to fund access to vaccines globally. I think that would be a really interesting idea. And there are ways that you might be able to then, get vaccines to somebody before they traveled. So basically, I think there are good reasons to want to improve the equity of vaccine access. But the fact of inequitable access to vaccines doesn't seem like a reason to be to reject the legitimacy of considering vaccination as a criterion for coming in, any more than like the inequity of access to money is a reason to reject the permissibility of requiring that you have a plane ticket. Or the inequity in access to visas is a reason to reject the visa requirement. So basically, I agree that it could compound some inequities and that we have reason to try to address that, but that I don't think the way in which it compounds inequity is unique or sufficient to justify not having it as a requirement in cases where it genuinely does reduce risk. There's a special example that I think is different that I do think is obnoxious, where some developed countries have excluded people who have gotten the very same vaccine but gotten the version of the vaccine that's manufactured in the developing world. So some EU countries were allowing people who received the AstraZeneca vaccine, but not the very same vaccine when it's produced, I believe, in India or South Africa as Covax. It's not Covaxin in India. I think there it's Covishield. And that does seem not justifiable because there it's not that the Covishield person poses a different risk than AstraZeneca. That just seems like it's the exact same thing. It's like, those cars that they have under two different names where you'll have, and that just seems like a proxy for nationality-based differentiation, which is not a reasonable thing to do in public health.
Right. Okay. So, well, now we're at the time where we have some student questions, and we're tracking a little bit behind. So let's try and keep the answers brief. I think it's been very valuable, the answers, but let's try and move through these fairly quickly. So the first one comes in from a student that says, you distinguish that immunity-based licenses are more practical than immunity passports because they can be better applied to activities of different severity. Would you want these licenses to vary not just by the current disease condition, but also the person? An example, an old person has a license with more restrictive properties than a younger person. So, yeah, what do you think about varying the degree of restrictions?
Yeah, so I think it would depend on understanding what exactly we're trying to achieve by way of licenses. With the example of an older and a younger person, I think one question is going to be, is it that there's a difference in the risk of spread? And there might not actually be. So if there's a difference in, if what we're trying to do is to reduce spread, there might not be a good reason to differentiate those licenses. In contrast, if what we're concerned about is the pressure on hospitals, the older person might be more likely to be severely ill if they get a breakthrough infection, setting spread aside. And so under that circumstance, it might be reasonable to have a differentiation, but in some ways it's not really a immunity-based license. It's whether it might be reasonable to consider other risk factors as well, sort of setting aside whether there is vaccination. So pre-vaccination, you actually had some states that said that people over a certain age shouldn't work in in-person childcare. And the reason why is that the concern is that high spread in that setting or in some settings would create an unduly high pressure on hospitals. So I'd say, just to try to keep it a little bit briefer, is I think it could be reasonable to have differences between different licenses, but it's important to think about what the objective is that the license is trying to serve. Are we just concerned about spread in this setting, or is there concern about hospital capacity? And again, that's going to depend on how pressured your hospitals are.
Okay, great. I wish we could have got to more questions. And depending on how much time you have after, we might be able to have a few more questions from the students. But
I can take a couple more.
okay. So, how can new science about the duration of immunity after receiving the vaccine affect immunity licenses?
Yeah, so it would affect it quite a bit. I think the question is, I think it'd be really great to get that science done to sort of to fund it properly, because I think a immunity license, same as with a driver's license, is only warranted as long as you are safer than an unlicensed person in doing the activity. So yeah, I think you would want to keep doing that research. I think right now, um, already we're sort of trying to understand the extent to which there's longer term protection against spread. But it seems so far like the protection against severe disease that could lead to hospital capacity risks has stayed pretty robust. So, yeah, I would say it absolutely matters, and it's really a scientific question. And my advice would be I hope that we keep and even sort of ratchet up the sort of funding of research to understand, uh, what vaccine schedule and what the duration of immunity is after a given schedule or type of vaccine.
Okay, thank you. That's good explanation. So the next one actually has to do with enforcement, and the student has said that the vaccine passports were implemented in New York City as a policy. However, nobody enforced it as multiple police precincts publicly acknowledged that they would not enforce it. Policy is obviously one part of the equation, but how can we encourage enforcement of these licenses and passports?
Yeah, that's a great question that I don't know that I have a. I mean, you don't. It's sort of striking, right? Because you don't see those of you who are college students, not to get too far into this, probably are familiar with the requirement of showing an ID to drink at a bar, or certainly probably familiar with the requirement of being licensed to drive. You don't see police saying, "Well, we're just not going to enforce the age rule at these bars," or we're not going to ask for license and registration. When people drive on the throughway. These three cities, Anianta's just not going to do that anymore. You don't see that. And I think maybe in part, and the striking thing is actually, I think there's much less public health benefit probably from making sure that nobody who's 18 drinks than there would be from enforcing that people have been vaccinated in, say, a crowded indoor venue or to go into a hospital or something like that. I guess there are two answers. One is that you might have in a setting like a hospital people who are genuinely committed to the public health goal of not having infections independently verify. So you might have somebody in the hospital say, look, you can't come in if you aren't vaccinated. We're going to check. This kind of gets back to this question about when you want police doing things and when you don't. Maybe the answer is to have people who are carrying out the verification who are not police. So public health or other officials. There's no reason why you would necessarily want police who are good at other things doing that. But there is a problem if you have police that are not committed to enforcing certain laws. And that's a broader question, I think, in society beyond the pandemic. I think a lot of people have complained about seeing police who won't wear their mask under the mask orders. And I think that's a real problem. And it's sort of a bigger question about having public officials that are committed to the public good.
Yeah. Okay, I have one last student question for you, and it's a little bit of a lengthy one, but let me approach it this way. So, government actions that suppress personal liberties have been permitted during the COVID-19 pandemic as special emergency measures to prevent death. However, the United Nations stressed that the fact that the state of emergency should not be abused during the pandemic. Once the vaccine is distributed to enough people and transmission rates are low enough, surely a declaration of a state of emergency would be inappropriate. Wouldn't continued restrictions of those without immunity-based licenses be infringing on their human rights? In other words, at what point must restrictions be lifted for everyone and not just those with immunity-based licenses?
So I think that's really going to depend on how COVID-19 evolves and sort of the danger of spread, right? So I guess I would reject the premise. I think that you don't necessarily need to have a state of immunity state of emergency, pardon me, we don't actually have an emergency anymore. But not having an emergency is going to depend on sort of
Hey,
how
Govind, why
effective.
don't you just repeat that? Just repeat that for a second. It was garbled. So I think it was
Sure.
an important piece. We don't want to
Let
miss
me
that one.
actually put it this way. So consider other infections like diphtheria or rubella or polio. Um, I don't think that we would actually think that it is a violation of people's human rights to, if there were sort of widespread outbreaks of polio or measles, to have some restrictions on people who were not vaccinated against the diseases. And you actually saw that in New York in 2019, I think, when there were measles outbreaks in some areas that had low uptake. So I think the question about whether you get to the point with COVID-19, nobody has to carry around proof of being vaccinated against polio because we don't actually have a problem where hospitals are being overwhelmed by polio patients, or you have to worry about your family member being paralyzed by polio when you go out. Um, I think the question is where you get when you get to a similar point with COVID-19. And I think it's it's not obviously clear. Remember that in some countries right now you still have to have proof of yellow fever vaccination to go there. um,
Mhm.
it's not clear that on the route we are now, COVID-19 very soon is going to look the way that polio and measles look, where we can kind of assume that there's such low risk that people don't need to have proof. And even despite the general rule, it's interesting that if you look at schools.
Hmm. Well, we can wait for him to jump in here. Otherwise, we can cut that and put.
Yeah, I'm not sure. So basically, I let the students go because the class time is out, and I was just going to thank Govind. There he is. Do you want to finish up, and then I'll just thank Govind, and we can let him go. I don't know how much time he has.
Um, did you want to finish the thought that you were on?
Sure. Yeah. Sorry, my stream got knocked off, and I'm sure the students are probably about done. Yeah. What I was gonna say is just with something like polio or measles, you still have to show proof of vaccination to go to school, which is actually a much more fundamental interest, human rights interest, education, than something like going to a concert or going to a football game or going out to eat. So
Mm-hmm.
I guess I would say that I'm a little hesitant to think that there would be a human rights violation as long as COVID-19 remains a more substantial risk than some of these other diseases. And in particular, given the permissibility of conditioning access to education on vaccination, it seems like it wouldn't obviously be a human rights violation to have a similar requirement for other diseases. I think would be my initial thought.
Right. Okay, perfect. So we're going to have one final thought, and the space that you have to get in for this to make sense is just to think, is there anything you'd like to leave the audience or the students with about you and the work you're working on? Any final messages about what we've talked about today?
Yeah, so I think one of the things that's been important about work in the COVID-19 pandemic is that it really is beneficial to have people working on questions who are working together with different types of expertise. So, people who have thought about ethical questions and ethical frameworks, people with legal expertise, with medical expertise, social science expertise. So, a couple projects just to highlight that might be interesting to the students was that I was working on a paper on vaccine uptake by age and race in the US with some colleagues at Minnesota who are demographers. And so that was really valuable because their expertise helped understand, people say some populations are more vaccinated than others. That actually sometimes depends on what proportion of ineligible kids or younger people who are less likely to be vaccinated they have. So the tools of demography can help us think about some questions that are relevant to pandemic response. I think another dimension that ends up being, I've been writing about and sort of been frustrated about some of these debates around boosters, because I feel like you often get people who are not, who are just trained as physicians, who make claims that seem sort of strange from a legal or ethical standpoint. So I saw some people saying, on the one hand, that boosters were, there's very, very strong evidence that they're effective. I think there's evidence that they're beneficial, but the evidence is not as clear as for the primary vaccination series. And you don't want to confuse people by being unclear about the fact that there are real differences in the degree of evidence. So philosophy of science, in a way, relates there. I think you want to have clear communication about, you can have a recommendation for both boosters and primary vaccination, but a different evidence base for one than the other. Then you see other people saying things like, well, we shouldn't even allow people to get boosters because it'll make unvaccinated people less likely to be vaccinated. And here I would want to see both social science research about whether that's actually true, and then also kind of legal and ethical investigation of whether it's appropriate to say to some people, you can't get boosters because of how other people will respond. Because we don't typically say, Nicole or Daniel can't get a drug because it'll affect what Govind does. That's not usually a reason to deny people access to medicine. So I think some of these really illustrate the ways in which integrating scientific, social scientific, and ethical and legal expertise is necessary to address a lot of the issues that we've faced during the pandemic. And I hope that in classes like this and other settings, you're getting a chance to see that expertise integrated.
Great. Thank you again for joining us today, Dr. Persad. It was a pleasure to have you. We'd like to thank the audience for joining us today, and we also like to thank our sponsors. This podcast series is a part of an epidemic ethics WHO initiative, which has been supported by the FCDO Welcome Grant 214711/Z/18/Z. We'd also like to thank Professor Nicole Hassoun for executive production, Dr. Ryan Woltz for writing and production, along with interns Ariana Rodriguez, Elizabeth Van Tassen, Noah Murachi, and Jenna Sifus. I'm your host, Daniel Sanderson, and I hope you enjoy this episode of Talk is the Best Medicine.
Thank you.
We hope you enjoyed this episode. To find more of our content or explore the exciting work being done by our parent organization, the Global Health Impact Project, you can check out our website at global-health-impact.org/new in the description below. The Global Health Impact Project hopes to continue to support efforts like this podcast to provide information about and advocate for access to essential medicines. Also follow the Global Health Impact Project's social media pages on Facebook, Twitter, and Instagram. Until next time, don't forget, talking is the best medicine.